My dear students, we shall have a small session on the pharmacology MCQs, which were asked in the last NEET 2023. Just to recall, and a very important thing to be remembered, my dear students, is that see, in your NEET exam, you have 100 marks for basics, 140 marks for clinicals. Okay? 140 marks for clinicals, part B, we will be able to tackle no problem. Part A, what happens is sometimes they go overboard. They give very similar questions which are even asked for the medical students beyond the scope of our dental fraternity. Irrespective, it's a challenge and we should give our level best to attempt these questions. Never ever, when you're attempting part A, when you find a tough question, don't hold yourself back. Don't get scared. Oh my God, everything is over. My NEET MDS exam is over. I've been studying for this exam. Nothing. Don't worry. Keep up your strength and go on for the full 3 hours. If it is difficult, most probably it is difficult for everyone. So please don't worry. Okay, right. So what we'll do is we'll just go through the questions of Pharmac. I'll just briefly explain. I'm not teaching you Pharmac in this session. This session is just to recall those questions, put those answers in your mind. It is not a teaching session. Please get this clear. Okay, because the first question on antidepressants and CNS I explained for 2.5 hours. This is a very small attempt to just tell you what the answers are. What is it that you have to know? Okay, chalo. So we start with the first question, but most important, never, ever, ever lose hope. I think never, ever. Okay, keep the faith up, keep working, keep studying, give your best for NEET, irrespective of how difficult it seems to be. It will be all right. Okay, chalo. So we'll just go through the first MCQ. Which of the following drugs come under the class of SSRIs? This is a simple classification based MCQ, right? But what you have to be very confident about this is key when you see those drugs, now which of them is an SSRI? And before I go into SSRI, my dear students, a simple concept is this, right? Depression, though the latest concept is a little different, but all the drugs are based on the concept what I'm going to explain to you. Now, depression, they say, is because of the lack of the monoaminogenic molecules, like, for example, lack of noradrenaline, lack of serotonin or 5-HT, what you see here, right? This is this one, serotonin, lack of noradrenaline in your brain or in the synaptic cleft is what is responsible for depression. So the minute you increase these molecules, they say that depression seems to be a little more better. So the major funda is to make sure that you increase the amount of these molecules like serotonin and your noradrenaline or dopamine, as the case may be, in your synaptic cleft. Clear? Now what happens? The minute these molecules are formed, the minute these molecules like noradrenaline and serotonin is formed, they are broken down, they are metabolized by a group of enzymes called monoamino oxidases. They can again be classified as monoamino oxidases A and B. A is what is majorly responsible for your 5-hydroxytryptamine and your noradrenaline. B is for dopamine and all that. Right. So these drugs, these enzymes, monoamino oxidases, metabolizes your noradrenaline and serotonin. So you don't want these enzymes to be active, right? So you put in a MAVO inhibitor to make sure that they do not they do not break these molecules down. That's the first mechanism of action. The second thing is the minute these molecules are released into the cleft, the body tries to reabsorb back again. So this concept is what is called as a reuptake mechanism. What happens here? Rather than being in the cleft, these molecules like noradrenaline and serotonin is reabsorbed back into your presynaptic junction. Okay, so you need something to block that reuptake and make sure that they remain there. Right? So if you see in this diagram here, there is something called TCA. TCA stands for tricyclic antidepressants. Now they are all reuptake inhibitors. SNRI stands for serotonin noradrenaline reuptake inhibitor. They also inhibit, I'll tell you the difference between both of them. They inhibit this reuptake back. On the other hand, you have SSRIs, which is what was asked for exams, that is selective serotonin reuptake inhibitor. There is a reuptake of this serotonin back again, and you don't want the serotonin to be reuptake back, to be reuptaken. So you block it by giving these SSRIs, by making sure that these noradrenaline and your serotonin continues to remain in your synaptic cleft. I hope you understand this. There are two main mechanisms in which you act. Okay, one, prevent the degradation of these molecules by MAO. Second, prevent the reuptake of these molecules by giving certain reuptake inhibitors. That's it. Finished. You've understood this. Let's understand the classification. Now, if you see this classification, they are classified as typical and atypical. Let's worry about typical. Typical is the first one, what I explained to you about MAO inhibitors. Okay? MAO inhibitors, monoamine oxidase. They can either be non-selective or they can be selective, right? Non-selective, like your tranylcypromine and your phenylazine. Now, these group of drugs are responsible for what is known as cheese reaction. You heard of cheese reaction? Cheese contains tyramine, cheese, beer, and all of that. And if you are on a MAO inhibitor, MAO is needed to metabolize cheese. Now you've taken cheese, but you've taken a MAO inhibitor, so MAO enzyme is blocked. The amount of tyramine increases, so you develop that particular cheese reaction. Simple concept, right? So you give MAO inhibitors. Selective is MAO A. Now, this selective, or the drug here is called moclobemide. It's also known as REMA, that is, reversible inhibitors of MAO A. Okay, it's also called as REMA, reversible inhibitors of MAO-A enzymes. So you have a drug there called moclobemide. But the most important drugs are not these. The most important drugs are these guys, your reuptake inhibitors. I've told you what are reuptake inhibitors. Okay, these ones, they will not allow to be reuptaken by. Now, this reuptake inhibitors can be classified as non-selective, like your TCA, most important one, right? You say tricyclic antidepressants. They include imipramine, amitriptyline. I'm sure there are some of you who have undergone or some treatment once in a while, and they have given you amitriptyline. So it is non-selective. It blocks both your serotonin and noradrenaline reuptake. On the other hand, you have SNRI. The SNRI also, if you see the diagram, blocks both. But the difference is SNRI does not have all the adverse effects what TCA has. TCA has a lot of adverse effects like anticholinergic actions, alpha blocking properties, and antihistaminic, none of which is there with SNRI. Okay, so SNRI includes a group of drugs like venlafaxine, duloxetine, and all that. Venlafaxine, duloxetine, and these are the drugs of choice. SNRIs, my dear students, are the drugs of choice for severe depression. Severe depression. Okay, right. Now let's take the drugs of interest. Your SSRI, selective serotonin reuptake inhibitor, wherein you have your fluoxetine. You can probably remember it as FPSC. You have UPSC, remove U and put F there. There are two with F. One is called fluoxetine, and then you have fluoxamine. You have P, which is paroxetine. You have S, a very important drug called sertraline, and then you have C. So the drug of interest is here, which is citalopram. So citalopram is an SSRI, or a selective serotonin reuptake inhibitor. I'm hoping that you understood this basic concept of reuptake and why you have to give a MAO inhibitor, okay, and what is REMA. Okay, it's a reversible inhibitor of MAO A. Only one drug there, moclobemide, and the other is non-selective MAO inhibitors. Okay, and then on the other hand, you have atypical antidepressants. Like, there are various mechanisms of action. The most important being your trazodone, which is basically a 5-HT2 antagonist. I think this much is more than sufficient for you to understand this particular MCQ based on classification only. So please get this very clear. We move on. So again, if at all there is a repeat, please know that the answer for this is citalopram, and it'd be good for you to learn the classification. And if you have seen the CD's lecture, it's a big 2.5 hours lecture. I'm hoping that you understood this quite well. Okay, right. Now the next one. Which of these is an aromatase inhibitor? Now, what happens is, first of all, what is an aromatase inhibitor? Why do you need it? Right now, I've decided to take this small particular session because most of the questions were a little odd, and you have to be very clear. And that's the reason why I thought a little bit of explanation will probably help you. Now, aromatase inhibitor is, in for people for patients suffering from breast cancer, Okay. A very important growth factor for these breast cancer cells is your estradiol. And in the postmenopausal women, usually what happens is in the peripheral tissues, your androgens are converted into estrogen with a group of enzymes called as aromatase, right? So, and especially this particular group of drugs like aromatase inhibitors are used for tamoxifen resistant. Now, you must have heard of tamoxifen in the classes. Tamoxifen is the drug of choice for your breast carcinoma and all that. So, wherever there is tamoxifen resistant breast carcinoma, tamoxifen resistant breast carcinoma, that is when you think of aromatase inhibitors. So, when you give this aromatase inhibitors, peripherally, this conversion that is taking place between an androgen and an estrogen, it stops. This is stopped. So you do not have estradiol. You do not have estradiol. It is something like you do not have a growth factor for your breast cancer cells. I'm hoping that this is clear, right? So this is what basic funda of understanding of what is aromatase inhibitors. Let's do the basic classification. The first generation of aromatase inhibitors is a drug called as aminoglutamide. The second generation being more important for us. The second generation, you have type 1, and again, you have type 1 and type 2. Type 1 is the irreversible one, steroidal. Type 2 is non steroidal, but it is reversible. Type 1, you have two very important drugs. You have many, but the first two you should know. It's called as letrozole and anastrozole. Letrozole and anastrozole is type 1. Type 2, on the other hand, you have two important drugs called as exemastane and you have formastane. So please do read them, exemastane and formastane. In type 1, on the other hand, you have drugs like letrozole and anastrozole, right? So these are, understand what is an aromatase inhibitor, why do you need to give it, and what is the indication. That is tamoxifen resistant breast carcinoma. Clear? Good. Now let's get on to, so the answer for this is exemastane. Okay, right. Penicillinamide. In the recently conducted exam, we had given all these poisonings, which are very important. So, penicillinamide is used to treat the toxicity of copper. Right, it's a straightforward question, but let's revise it quickly. Dimercaprol or BAL or British anti-leucite is used for arsenic poisoning, lead poisoning, mercury poisoning, and all that, but contraindicated in iron and cadmium poisoning. The calcium sodium diadeate is the one which is most famous for lead poisoning. Lead poisoning. Okay. D-penicillamine is used for your copper poisoning, and iron poisoning we use desferoxamine. Desferoxamine. Okay. Got it? So I'm hoping that you will just go through this and you'll keep it in mind. These are the most important drugs for toxicity, right? Dimercaprol or BAL, calcium disodium mediatate, penicillinamide, desferoxamine. Okay, right. So the answer is copper. Next, which of the drug is a drug of choice to treat PSVT? Again, a very simple, straightforward question, thankfully. Now, PSVT or paroxysmal supraventricular tachycardia, the name is scary, but the disease as such is not that scary. One of the, if at all you want to treat it by drugs, then one of the most important drugs given for acute treatment of PSVT is adenosine. The half-life is a few seconds, and that's how we can treat this arrhythmia, which can usually come about. But sometimes you need to treat it by what is called as catheter ablation. Catheter ablation is said to be a simple outpatient procedure, and the patient becomes fine, right? So otherwise, yes, for acute cases, you can give the patient adenosine. So you see this. If there are no limiting symptoms, you ideally don't need any treatment, even though you may be suffering from PSVT. Okay, right. So, but catheter ablation is almost like the thing which you have to do. But when it comes to drug therapy, or when you're talking of drugs, then of course you can think about adenosine for an acute case of PSVT. So the answer is over here. The best answer is adenosine. Which medication is most commonly implicated for the development of Clostridium difficile infection? Among these, the best answer is your clindamycin. This is a straightforward question which we have been discussing always. Clindamycin. Now, there is a new drug which has come about, which is an immunoglobulin, or as we call it, as a monoclonal antibody. The drug is called as bezlotoxumab. Bezlotoxumab. Now, this bezlotoxumab is a fully It's an FDA approved drug. Okay, first of all, it's an FDA approved drug. Bezlotoxumab is a fully humanized immunoglobulin kappa monoclonal antibody which binds to Clostridium difficile toxin B and neutralizes its effect. So please do remember this particular drug of choice. And obviously, when you're having a Clostridium difficile infection, then you majorly treat it with vancomycin and the other drugs, right? But implicated, okay, you have even your cephalosporins which are implicated, but among these the best answer is clindamycin, and the new a new drug which has come about is known as bezlotoxumab. Okay, please remember that. Next one. Allopurinol used to treat gout acts by which inhibition? You all know that allopurinol is basically used for for gout treatment, and gout is because of excess of uric acid in the body. We'll just go through this very quickly. Treatment of gout. Whenever you're having acute gout, you do not give any of the other main drugs like allopurinol, febuxostat. No, acute gout is pain. So for pain relieval, you can think of NSAIDs, colchicine, steroids. NSAIDs being the best, like indomethacin. You do not give colchicine because of its adverse effects. Now, when it comes to chronic gout, please look at it like this. The chronic gout has, first of all, you do not want uric acid to be produced in the body. So you give a group of drugs which decreases the synthesis of uric acid. Secondly, if at all uric acid is produced in the body, you want to increase the metabolism so that you can flush this uric acid away. So what do? You increase the metabolism of uric acid, and that is where you have these group of drugs coming in. Rasburicase. Rasburicase was asked in 2022. Okay, so this classification is super damn important. Then, even after metabolism, there is still amount of uric acid remaining. Then you'd like to flush it out of the system directly. Then you increase the excretion of uric acid. You have 4 drugs over there. So let's do this very quickly. Drugs decreasing the synthesis of uric acid. You have purine and non-purine based. Purine is allopurinol, whereas non-purine is febuxostat. My dear students, I am a little quick, I am a little fast. I'm not teaching you, I'm just revising. Okay, and you don't have time. It's a last minute recall, so let's do it quickly. The other one is drugs which increases the metabolism. It's a human recombinant form of an enzyme called urate oxidase, right? Which is majorly seen in birds, not in humans. So you convert them into what is called as rasburicase and pegloticase. And drugs increasing the excretion of uric acid. You have 4 drugs there. One is called as probenecid, sulfenpyrazone, benzbromarone, and you have a drug called lesinurad. So please do revise. Very important classification for gout, also from the general medicine point of view. Now the question is not the classification. The question is asking, how does allopurinol, how does this guy basically, allopurinol inhibits the enzyme called xanthine oxidase. Now, if you see this particular chart here, purines are converted to uric acid. Purines are converted to hypoxanthine, hypoxanthine to xanthine, xanthine to uric acid. Now, this conversion needs this enzyme called xanthine oxidase. And it is this enzyme called xanthine oxidase which is blocked by allopurinol. How does it block it? It's a competitive blocker. It's a competitive blocker. So please do understand, allopurinol blocks xanthine oxidase in a competitive inhibition mechanism. Right? Got it? So I think we'll move on. So the answer for this is competitive inhibition. Keep this in mind. Let's go on. Anti-anginal drug having an affinity for cerebral blood vessels. There are lots of anti-anginal drugs. The classification of anti-anginal is amazing. We've done this, but the best answer among these, which can act on the cerebral blood vessels, is nimodipine. You also have another drug called nicardipine. Both of them, nimodipine and nicardipine, can act on cerebral blood vessels. But among the options here, the best answer is nimodipine. A few things which I'd like to tell you. Nimodipine is a short-acting dihydropyridine. You know what's a dihydropyridine? Drugs like amlodipine and all of that is a dihydropyridine. But it can penetrate the blood-brain barrier because of its high lipid solubility. Zoom, it just enters the brain, okay? And it's a very high affinity for the cerebral blood vessels. Unlike the other anti-anginal drugs, this fellow goes straight into the brain, okay? It can be used for, now just look at this, it can be used for prevention and treatment of neurological deficits which could arise due to a cerebral vasospasm following a if the patient is having a subarachnoid hemorrhage and is having a cerebral vasospasm, and then before that vasospasm actually causes the various problems, neurological deficits, put the patient on nimodipine. So that is what he is saying. So short acting dihydropyridine. Got it? So the best answer for this is nimodipine. Right? Let's move on. Which of these comes under the class of antiplatelet drugs which inhibit? This again is a straightforward classification based question. So let's do it again on glycoprotein 2A, 3B. Let's recap this classification. There you go. The most important antiplatelet drug is aspirin, which you know is a COX inhibitor. And then you have a drug called dipyridamole, which is a phosphodiesterase inhibitor. Then the most important group of antiplatelet drugs, if you have somebody in the family who probably had a stroke or is having a tendency of that, then immediately you see that the patients are put on aspirin and clopidogrel. The two drugs they're immediately put on. So this particular clopidogrel is an irreversible ADP or a P2Y12 antagonist. You have three important drugs there: ticlopidine, clopidogrel, prasugrel. Most important group of drugs in this entire antiplatelet is this guy here: ticlopidine, clopidogrel, prasugrel. Reversible, you have two drugs which called as cangrelor and tisagrelor. The answer for this question, that is glycoprotein 2B3A. You can always remember the password called ATE or EAT, but I think I better put it as ATE because the drugs, the order of importance of drugs are like that. So A stands for apixaban. You can see the drug there, apixaban. T stands for a drug called tirofiban, and E stands for a drug called eptifibatide. Okay, PAR, that is protease activated receptor antagonist. You can remember it as PAR. So the drugs are vorapaxar, atopaxar, and all that. Okay, so please, my dear students, classifications are super duper important. 1 mark scored, you're going to beat your competition by at least like 400 ranks. Okay, please make sure that you revise all of it 1 week before your exams, right? So ADP antagonists, you have reversible and irreversible. It's irreversible. It is ticlopidine, clopidogrel, prasugrel, and reversible cangrelor, tisagrelor. Your glycoprotein 2B3A, ATE, apixaban, tirofiban, eptifibatide, PAR antagonist, vorapaxar, atopaxar. Very simple. If you remember the class, we have revised it like that, isn't it? Okay, my dear students, let's move on. So the answer for this is apixaban. Next one. Which of the following anesthetic agents acts on NMDA receptors? Okay, this is among your anesthetic agents, and one of the most important one, your ketamine. Ketamine blocks the excitatory NMDA receptors, as can be seen in this particular diagram. The NMDA receptors are located at pre and postsynaptic terminals. How it blocks is NMDA ideally allows the entry of sodium and calcium into the cell while letting potassium ions out. Don't worry about all that. Ketamine blocks NMDA receptors. Just watch this. Ketamine blocks this receptor, decreasing its excitatory actions, and that is how ketamine acts as a general anesthetic. Now, when it comes to ketamine, there are a few points which I would like you to know. First one, the word dissociative anesthesia is associated with ketamine. Second one, in children, it is the intravenous agent, drug of choice, intravenous anesthetic of choice for induction in children, not inhalation. Inhalation is sevoflurane. Through IV, it is ketamine. Next one, it is a powerful bronchodilator, so it's a very important IV agent of choice. If people are having bronchial asthma, you put them on ketamine because it's a very, very powerful bronchodilator. Another important, but one big disadvantage is that it increases all the pressures in the body. It increases your BP, it increases your pressure in the brain, so that increases your ICT or intracranial tension. It increases pressure in your eye. That is, there is increase in intraocular pressure. Okay, so all of this is about ketamine. So please get these points inside you. Ketamine acts on NMDA receptors. NMDA. Okay, next. Right, that is the answer. Which NSAID has the least straightforward question and least anti-inflammatory effect against all? The answer is paracetamol. I don't think I need to explain that, right? Which of the drug is an absence seizure? If you look at the options, see, valproate is a hero. Wherever you have valproate, you think of that guy. Okay, and then among this, but he's given both A and C. If he's given A and C, obviously the best answer is both A and C. Ethosuximide and valproate can be used for absence seizures, right? Let's go through these drugs of choice. Grand mal, petit mal, both valproate. Focal seizures, you can go for carbamazepine. Myoclonic, atonic, again both valproate. Febrile seizures, you give diazepam. Status epilepticus, you give lorazepam. Eclamptic seizures is magnesium sulfate. Epilepsy in pregnancy, you can go for drugs like lamotrigine. Okay, done all of you. So please understand, valproate is a hero. But the answer for this, because you have ethosuximide, both of them can be used in absence seizures. If given a choice, maybe valproate. Next, which of these anti H1 antihistaminics has the least anticholinergic action? Now, see what happened is last year the pharma questions, though there was some of the questions like this were a little out of the boundary in the sense we've done it in the class and all that, but students have just hardly done a little bit antibiotics here there that then there are more than 17 to 18 questions on pharmac. It's very difficult for you to score, right? So yeah, so please make sure that you please do revise the all the important classifications before you go. And if you see all the last 7 years of NEET papers, pharma comes for roughly around anywhere between 10 to 16 or 10 to 17 questions. Now, which is antihistaminic has the least anticholinergic action? I'll show you that. Now, if you see this table, this is basically classified as highly sedative drugs, moderately sedative, mildly sedative, and second generation antihistaminics, which has got even lesser sedative action. Highly sedative, I'm sure you remember this cough syrup, Benadryl, which probably you had taken when you were children, contains diphenhydramine. Then there is promethazine. All of these are highly sedative histaminic drugs. H1 antihistaminics. Moderately sedative, you have phenyramine and you have cinnarizine. Cinnarizine sometimes is taken for vertigo, right? Then you're mildly sedative, you have chlorpheniramine and all that. Second generation, I'm sure that there are some people with allergic rhinitis who probably take Allegra. Allegra is the one which is which contains your drug called fixofenadine. And I still remember one student saying me, sir, I have taken Allegra, I know the drug, help me in the exams. Well, well, okay. So it's fixofenadine, and you must have heard of this drug called cetirizine, levocetirizine. All of them are your second generation antihistaminics, right? Now, this table is what tells you the basic list, which are the ones which have the maximum anticholinergic and the one which has the least or minimal anticholinergic action among the antihistamines. So the highest is promethazine diphenhydramine, which we studied. They have the highest anticholinergic action. Low is chlorpheniramine and all that. Let us not worry. But minimal or absent is fexofenadine, loratadine, cetirizine. Are these the most commonly taken drug like cetirizine, levocetirizine is minimal or absent. Allegra, fixofenadine, no problem, no problem. On the other hand, promethazine, diphenhydramine, phenyramine, all of them have very high anticholinergic action. Okay, so the answer for this is fexofenadine. Antihistaminic has the least anticholinergic action. Next, which medication, when given in large doses, can cause severe ototoxicity? I think it's a straightforward question among diuretics. It is your furosemide. The other adverse effects of furosemide, in fact, the ones which are more important, it causes hypokalemia, hypomagnesemia, hyponatremia. It causes hyperuricemia, hyperglycemia. Hyperglycemia, so don't give it in diabetics. Hyperuricemia, don't give it in patients with gout. And it causes what? Hypokalemia, hypomagnesemia, and hyponatremia. Okay, all of you? Done. Next. Which is the drug of choice to be administered in a patient with nephrotic syndrome? Simple, straightforward, right? Nephrotic means what? Means there is a loss of proteins from the blood through the urine. So you'd like to give something to the child. So the best thing to give him is to put him on steroids like prednisone or prednisolone. This is the drug of choice, and they've seen that within a period of 3 to 4 days, the patient becomes better. And many a times they go into remission just by giving steroid therapy. You don't really need to do anything else, right? They're called a steroid sensitive nephrotic syndrome. Sometimes they are steroid insensitive. Then you might have to change the course of action. Okay, so I'm hoping that this is clear about prednisone. The next question is speaking about muscle weakness and severe cramps and all that, and he has myasthenia gravis. So straightforward question. He should have just asked, a patient is having myasthenia gravis. What are the receptors which are blocked? The answer is nicotinic receptor. Got this? Okay, so let's read this again. So in people with myasthenia gravis, these are the nicotinic receptors, right? So you have the acetylcholine which is released. It cannot come and bind to these receptors because there are antibodies, as can be seen in the diagram. Suppose this is the receptor, antibody comes and sits onto this, as a result of which you have the acetylcholine coming. It cannot bind to the receptor because you have the antibody sitting there, as can be seen in the diagram. Nicotinic acetylcholine receptor, you have the antibody which sits on this receptor, thereby blocking the acetylcholine from interacting with your nicotinic receptors. There you have myasthenia gravis. Okay, and I'm sure that you have heard of hydrophonium tests and all that. Let's move on. Okay, so the answer is nicotinic receptors. Right. Valcyclovir is not given. A pretty different question. Valcyclovir, a congener of acyclovir, can be given for zoster, herpes simplex, genital herpes. Do not give it for geriatric patients who are older than 75 years. Um, um, Simply because they can cause what is known as neurotoxicity, right? It can cause neurotoxicity. Also, valcyclovir can, in patients who are above 75, if there is a little amount of kidney dysfunction, then valcyclovir will make it worse. So you have to be careful in people who are aged, above 75 years, or basically geriatric patients. Do not give it to them. Next, which nucleus of the brain is particularly associated with addiction? This is another question, right? Out of the world. Now, which nucleus? So this is basically, he's talking of dopamine. So the more and more of dopamine which sits in this particular nucleus, the more and more you get addicted. There is this nucleus. This is the nucleus which is known as nucleus accumbens. The answer for this is nucleus accumbens, which can be seen here. And what they have seen is, you know, they've done the study. It's an amazing study. Suppose, let's say that you're very tired and all that, and you eat food, okay, and you feel very happy. This is again sensed by this nucleus accumbens. Wow, and you feel very good, and you can go on eating. And every time you eat, and after some time, like once you've eaten, your this can also be like your reward center, gift center, happiness center. This fellow, okay, and he senses that you're full, right, and then you don't feel like eating, right? But in cases of drug abuse, they have seen that a patient takes a drug, this fellow, he doesn't tell it's enough. He tells, okay, give more. And then you take the second, and then you take the third, and then you take the fourth, and then you take the fifth. And, because you know why? There is no satiety. The people, they want to take it again and again because this guy, nucleus accumbens, is not giving the signal to the body that it's enough. So he responds differently to different things. This study has really proven that food or probably music, anything for you to feel happy or whatever, after some time, the accumbens tells you, the nucleus accumbens gives a signal that it's done. But for drug abuse, he just keeps quiet, and somehow that is how many, many, many children, young people are falling into drugs. This guy is the culprit, nucleus accumbens. Okay. So this guy is said to be the functional interface between the limbic and the motor systems. For addiction, it's all got to do with dopamine, but they've seen that this NAC is nothing but nucleus accumbens. It's given everywhere, right? Depression, OCD, bipolar disorders, anxiety disorders, Parkinson's, you name it. It's been associated with a lot of conditions. Okay, done. Let's move on. So the answer for this is nucleus accumbens. Okay. Right. Which drug is very potent against the trophocytes of Entamoeba histolytica? Entamoeba histolytica is basically a protozoan which causes amoebiasis. है ना? Right? There you go. This is the guy which causes amoebiasis. And one of the drugs to be given is your antiprotozoal drug like metronidazole can be given for patients who are suffering from this. Got it? These are all the MCQs which had come for your exam last year. So there were a different set of questions, not very straightforward, not very easy, and needed a little bit of extra knowledge for you to, to arrive at the answer. Now, I want to come back to this particular table. These drugs, SNRIs or serotonin noradrenaline reuptake inhibitors, are the ones which are used for cases of severe depression. But when you start off a treatment, first few, initially you would like to start off with mild cases of depression or something you want to start off, you always give the patients SSRIs. So SSRIs are the first drugs of choice to start off with mild cases of depression, with patients who are having OCD, you're having bulimia, or they're having premenstrual tensions, and all these things, panic attacks, and all that. Sometimes they put them on this group of drugs called SSRIs. Okay, so hoping that I've done justice to the set of the 16, 17 questions, and please learn the answers. Uh, Understand a little bit. Don't go understanding too much about it, but just understand what is needed and keep up the hope. Never lose hope. Given your best, especially when you're writing basic questions or part A. You might suddenly feel that, my God, everything is over. It's not like that. They say, in Hindi, picture abhi baki hai mamu. Matlab, you have to use those 3 hours. Use those 3 hours. You are there for those 3 hours. Use those 3 hours completely, until and unless your exam is over. You will not analyze the paper. You're just going to sit there and give your best for the paper. Okay, all of you, take care. Wish you all the very best and do well. Thank you so much. Thank you.